And I'm going to start our recording and remind people that keep your self muted until we have the open time for questions, and that if you don't want to be on camera inadvertently, then make sure that your camera is turned off as well. So Dr. Eldridge, I would like to turn it over to you, and thank you very much.
Thank you so much. It's great to be here today. I appreciate the invitation to come and talk, and see a lot of familiar names and faces on the in the little boxes there. So it's great to see a lot of my team members on here today. So today, well, just to let you know, I'm Chad, one of the infection preventionists at the HAI program, which Dr. Carrico said. I serve as the HAI Outbreak lead, and also I'm currently serving as the NHSN lead at the state. And today we'll be conducting a very brief, high-level overview of Carbapenem-Resistant Organisms. So my position allows me to have conversations with IPs in a variety of settings all across the state, such as acute care hospitals, long-term care facilities, hemodialysis clinics, wound clinics, surgery centers. If there's an IP in a facility, chances are we're going to talk to you at some point, somebody on our team. There's been a lot of turnover of staff in infection control in all of these settings. Some of this turnover occurred just before COVID hit. Some happened during COVID, and we are actually still seeing it. And so the turnover, especially during COVID, has left IPs to figure out things on the fly. They haven't had much time dedicated to learn some of those basics of infection control and some of the basic language that we use. So a lot of times I'll be talking with an IP on the phone, and they tell me they feel like I'm speaking a foreign language. They're unfamiliar with CROs, they're unfamiliar with that common language. And so today, this is a judgment-free zone, okay? This will be an overview of CROs. For many of you, this will be a basic review. And for some of you, this will be an introduction. It's impossible to go into a lot of detail in 30 minutes. So there again, high level. Today, we'll be focusing on those important CRO basics. Basically, the 5 R's, what I've surmised into 5 R's of CRO. First of all, we're going to review CROs in basic language. We're going to look at a response, how an IP would respond to those CROs. We're going to look at the regulation, our state regulation, and where you can find that. We'll look at reporting requirements. For those of you keeping score at home, that's 1R, reporting. And then we'll look finally at recent trends in the state. So here's our learning objectives. At the end of the presentation, you should be able to differentiate between CROs, CREs, MDROs, CPs, CRPAs, and CRABs. To some of you right now, that seems foreign, but we'll get into the details. You'll be able to describe the key elements of CRO containment, response. You'll be able to discuss commonly identified infection control gaps. You'll be able to identify the location of the state reporting regulation, because if you are not aware of that, it's very important. You'll be able to discuss those reporting requirements that we have at the state, and you'll be able to understand the current status of outbreaks and what we call PPS, or point prevalence surveys in the state. Very simple vocabulary review. These are some words that you'll hear often today. You'll most definitely hear it if you get a call from someone in our program. I do want to point out that these words seem similar, they're quite different. And when people use them as synonyms, it can really get confusing, because they're not, although they're similar, they're not the same. Multi-drug resistant organism, or an MDRO, that's something that we would describe. It's a very sort of generic term to describe a wide range of organisms. A carbapenem, we'll get into that a little more later, but that's type of antibiotic. And then you got a lot of Carbapenem-resistant organisms, well, listed below. But first of all, the word Carbapenem-resistant organism, again, a broad term to describe a large amount of organisms. Carbapenem-resistant Enterobacteriales, or some of you may remember Enterobacteriaceae. There was a recent name change, so that's CRE. Carbapenem-resistant Acinetobacter baumannii, which unfortunately is a reason why I make a lot of phone calls, CRE and crab. And Carbapenem-resistant Pseudomonas, CRPA. So you can see real quickly that they're all mouthfuls. So there's a reason why when I call you about crab, and you know, you can get tongue twisted really quick. We'll talk later about point prevalence surveys, but those are PPSs, is how we refer to those. Those are general surveys that rule out horizontal transmission or find horizontal transmission of these organisms in various facilities. And then Carbapenemase producers. Now, this is the one time that there are some, these are synonyms. So I might describe a Carbapenemase producer, or I may call it a Carbapenemase gene, an organism with a Carbapenemase gene, or an organism with a mechanism, or an organism with a CP. Those all mean the same things. We'll get into that in a little bit more detail in a little bit. But if I say that an organism has a Carbapenemase gene, that's the same thing as saying it's a Carbapenemase producer. That's the same thing as saying it has a Carbapenemase or has a mechanism. The words that most often get confused are Carbapenems, Carbapenem resistance, and Carbapenemase. They sound similar, but three very distinct things, and we're talking about three different things when we talk about Carbapenems, Carbapenem resistant, or Carbapenemase. So we'll get into some details here about CRE, or not necessarily CRE, Enterobacteriales, or as I said, formerly Enterobacteriaceae. So these are common examples of Enterobacteriales. So you've got your Citrobacter, your Enterobacter, your Morganella. Now, when these organisms become Carbapenem resistant, that's when we classify them as CREs. So if all of these organisms on this list were resistant to Carbapenems, they would all be classified as CREs. These organisms can have a Carbapenemase gene associated with them.
Thank you.
So I've made a note here to distinguish Klebsiella pneumoniae, which is an organism, from KPC, which is a Carbapenemase gene. A lot of people early on will get confused by this. What KPC stands for is Klebsiella pneumoniae carbapenemase. And that's a gene that can be found in Klebsiella. It can actually be found in any of these organisms listed here. So if I were to call you and tell you that one of your patients had an Enterobacter cloacae with a KPC, I'm not telling you that they have E. cloacae and Klebsiella pneumoniae. Now, they actually, I suppose, could, but in this case, if a Enterobacter has a KPC, they don't have two organisms. They have one organism that has a gene, a Carbapenemase gene attached to it. And we'll get into a little more detail on what that Carbapenemase gene, what that means. Another way to say that would be this E. cloacae is a Carbapenemase producer, has a Carbapenemase gene, has a CP, or I may say that, hey, this has a mechanism, and the name of that mechanism is a KPC. What you don't see on the list is crab or Acinetobacter baumannii, or Pseudomonas. So those are not Enterobacteriales. So sometimes I'll call and we'll be discussing crab, and the IP will switch sort of the conversation over to talking about CREs. So those aren't CREs, and that's a common misunderstanding. They are CROs. They're under that general umbrella of Carbapenem-resistant organism, but an Acinetobacter would not be a CRE. So here's a little bit more detail about carbapenems. We mentioned carbapenems earlier. Those are broad spectrum antibiotics of last resort for highly resistant infections. They became increasingly important as ESBLs came on the scene back in the 90s. And currently in the United States, we have 4 approved carbapenems. So imipenem, meropenem, doropenem, and ertapenem. And we find that ertapenem is less active against some bacteria. So, why this is concerning, our talk today, is these antibiotics are a last resort of highly resistant infections. And some of these carbapenemase genes are causing them not to work, leaving us with few, if any, options for treatment. So carbapenemase producing organisms, or organisms that have a mechanism, or organisms that have a carbapenemase gene. Okay, so there are organisms that have a gene that produces a carbapenemase. And that's essentially, it produces this little enzyme that when we send carbapenems in to kill that organism, this enzyme just digests that carbapenem. It just melts it. Another thing that these genes can do is they can produce a biofilm around these organisms. So that makes these organisms a little more hardy in the environment, which allows for more successful transportation. So I tell people, if you've been on a call with me, you've heard me say this before, you could put a crab with a carbapenemase gene on a bedside table, and you walk away, you close the door, you don't have to feed it, you don't have to water it, you don't have to talk to it, you just walk away. 15 months later, you come back and it's still there and it's waiting. It just can't wait for you to pick it up on your hands or your scrubs and take it down the hall to some vulnerable population. So this biofilm makes it a little more hardy in the environment. And they also can be plasmid encoded. So they can pass resistance vertically or horizontally. Now what I mean by that is vertically, so as the organism replicates or reproduces, it can pass that along to its so-called offspring. Or horizontally, it can actually pass on to other gram-negative organisms. That's why KPC is very confusing. It's a confusing carbapenemase, because back, I think in 2001, when they found the very first gene, carbapenemase gene, they found it on a Klebsiella pneumoniae. And what do you find? What do you name a carbapenemase gene that you first find in Klebsiella pneumoniae? You name it Klebsiella pneumoniae carbapenemase, KPC. Makes sense. Little did they know that this thing could pass it on to other organisms. And so we don't name our carbapenemases like that anymore. That's why you see oxes and that kind of thing. So why are we so concerned with CP genes, carbapenemase genes? Well, one, they melt our last line of defense against these resistant organisms. They're associated with much higher mortality rates, up to 30% higher. I actually read a recent study where it can be up to 50% higher in some cases. They're harder to treat. The reason they're getting harder and harder to treat, and probably the mortality rates climbing, is because these organisms can become non-susceptible, which means it's not susceptible to any antibiotic, although it's intermediate to some, and can become pan-resistant. So these organisms, especially with these genes, can become resistant to every antibiotic that we have on the market. So no antibiotic will effectively treat the infection, thus driving the mortality rate up, especially in those vulnerable populations, those ICUs, long-term care facilities. And these organisms can colonize in the gut, and sometimes they can colonize on the skin. And these colonized organisms, they can convert to infection in that individual. They can be transported to infect others, and they are not harmless. A lot of people will think that, okay, it's colonized, it's harmless. That's not the case. Currently, it's causing no harm, but it can infect that individual if it gets in through a line or gets into an open wound or through an oral ET tube, or, like I said, can be passed on to other individuals. And we'll be discussing some common myths concerning colonization in just a little while. So these are common examples of carbapenemase genes. If you've been on the phone with me, I'm probably calling you about some kind of a carbapenem-resistant organism that we found a carbapenemase gene in. So oxycylinase, we have the OXA23s, the OXA2440s, the OXA48s. Those are common ones we see. And then again, the KPCs, the NDMs, the VIMs, and the IMPs. And again, you can see why we, shorten the names of these, because it can definitely be a mouthful. So these can all be found in various carbapenem-resistant organisms, as discussed. OXA23, OXA2440, they're commonly associated with crab. KPC, NDM, VIM, IMP, OXA48, commonly associated with CREs. KPC, the most common carbapenemase producer in the United States. Although NDM, VIM, IMP, although they're less common, they're still concerning because they can be more resistant to even more antibiotics than KPC. So the response. One thing I don't think I listed here is early identification. Early identification is key to stopping transmission. And unfortunately, I talk with a lot of IPs that they don't want to know. We want to do a PPS. We want to make sure that there's no horizontal transmission, and they really don't want to do that because they do not want to know if something's in their building. Well, that's scary, because whether you know it or not, that organism can be there, and it can spread, and it can spread silently, and then it can eventually get to that person that it overtakes and causes death. So early identification is key. Some facilities have set up admission screening to identify when these organisms enter their facility. And then when necessary, I mentioned PPS, that can help identify any unknown colonization in a facility to prevent silent spread of that organism. So other core infection control practices would be standard precautions, and certainly including hand hygiene, transmission-based precautions, contact precautions, environmental infection control. So daily enhanced environmental cleaning, cleaning of that mobile medical equipment, and those high-touch surface areas. I recommend ongoing competency assessments and ongoing adherence monitoring. What are your compliance rates with hand hygiene? What are your compliance rates with your PPE? And I recommend that you audit that and that you get data sets for that. And then certainly interfacility communication is one of the biggest keys on this list. We see a lot of transmission that occurs because of lack of communication. So as far as for your facility, be sure that your lab is alerting you when these carbapenem-resistant organisms are identified, so that you can immediately begin the response. You can immediately put that individual in contact precautions. I want to note that the IP's response is the same for a CRE, CRPA, a crab, with or without a carbapenemase. You're still going to do contact precautions. You're still going to, do all of those things. And so, get that going, and make sure your lab is telling you in a timely fashion. And again, be sure that this information is passed along when the patient's transferred, whether they're transferred to another unit, another hallway, another facility. We strongly encourage statewide use of an interfacility communication transfer form. And I think there are some facilities across the state that are piloting that, and they like the results. And like I said, much of these things listed really should be ongoing. Those competency assessments, adherence monitoring, hand hygiene, PPE, cleaning of those high-touch surface areas with audits, and solid interfacility communication. These are some commonly identified infection control gaps that we see. We see lack of accessible resources, and I hold leadership accountable for that. There are many times we'll go into a facility and there just aren't many hand hygiene stations, or there's no PPE available. And you'll talk to leadership and they say, oh, we got tons of PPE. Yeah, they have it available. All you have to do is you go down to the nurse's station, you get into the drawer, you get the key, and then you take the key, you open the locked box in the medication room to get another key. Then all you have to do is go down to the end of the hall and unlock that closet, and there's all the PPE there you could ever want. Well, that's not reasonable, and more than likely, people aren't going to do that every time they need, a pair of gloves. So, I think it's up to leadership to make it easy for your staff to do the right thing. And so I can't put enough emphasis on that. There's a lack of hand hygiene and PPE compliance. And there again, I think you should be auditing frequently, daily, weekly, coming up with data points that helps you to understand your compliance rates, and give feedback, not only provide those audit rates up the chain, but provide feedback to your staff. Failure to clean mobile equipment, failure to distinguish between clean and dirty. We see storage supplies in the splash zone, which many of these organisms we're talking about are water bugs, and so they can be just carried in then from those splash zone areas. And lack of proper environmental cleaning, so they're not doing those high touch surface areas, they're not doing the appropriate dwell times, and they're not using that elbow grease. And so GlowGerm can help you see cleaning and how it's being done. I really am a strong proponent of GlowGerm. I think you as an IP, or you have your EVS lead, you guys pick out 15 to 20 different areas in a room that are high touch, remote controls, bed rails, light switches, and you pick out 15 to 20, but per room that you audit, maybe you just put 5. You put that GlowGerm on 5 areas. Maybe it's light switch 1, it's the 2 faucets in the bathroom, and then you go back and audit that. If you did 5 in one room and 5 in another, now you've got 10 data points that, well, you went back and 3 of those GlowGerm areas were never touched. So that's that's an opportunity to understand what's getting missed. It's an opportunity to show visually your staff what's getting missed. And it really shows how much elbow grease is going into it. Because sometimes with a spot of GlowGerm, you might see where something was swiped at. Either it was completely missed, maybe it was just swiped at and smeared, or it was clean. So it can help you. It can help you know those things. And it can also not only help you know what's commonly missed in rooms on those high touch surface areas, but maybe it shows you something about a particular unit. Maybe a unit has lower compliance rates because they really push fast turnover and people don't have time to clean the room appropriately. So you can get a lot of interesting data based on that. there are a lot of common myths. Number one, CROs are not a big deal. That's false. They are a big deal, and they kill people. They're associated with increased mortality rates. Another myth, it's everywhere. We can't really do anything about it. Well, that's not only false, but it's scary to hear, and it's scary for IPs to say that, I think. Usually the answer to stopping the spread is very, very simple: hand hygiene, PPE, EVS. There's denial. This can't be right. This resident hadn't been out of the facility for years, and she doesn't leave her room. Unfortunately, that probably means staff brought it into her. She didn't go out to the facility and get it. She does have it, and staff brought it to her. Oh, it's colonized, not a big deal. Again, false. That same organism can cause an infection in an individual, and that individual or someone else. Another myth, well, it's in the urine and they have a Foley, or it's in a wound, or it was in a wound and now that's healed. So we no longer need contact precautions. Well, that's false. Again, colonization in the gut, sometimes the skin, calls for ongoing contact precautions. So those are just a few myths that we deal with, and there are certainly more that I could share with you. I want to call your attention to where you can find the state regulation for reporting. If you click on this link, or if you copy and paste this link, you'll always have the most recent version. When the legislation meets, occasionally we will change things in the regulation. So this will always get you the most up to date. Call your attention here to 3 sections of the regulation. Section 3, which you want to read. It's about submitting specimens from the lab. Section 10 covers multi-drug resistant organisms, and then Section 11 covers those that require priority reporting by EPID 250 and sending in those labs, those MICs. And that's these 5 organisms here: Candida auris, Carbapenem-Resistant Acinetobacter, and so on and so forth. So reporting, please send in those EPID 250s and those MIC values. We have a new and improved PDF fillable form for that EPID 250. I can share that with Ruth, and she can get it out to everyone on the call if you don't already have it. Send that to our secure fax number, please. You might say, well, what about reporting to our local health department? Well, I can't ask you not to do that. They want that information. They may have requested that information. So certainly you can share that information with them, but please at least get it to us. And I just want to note that the Kentucky State Lab does not perform confirmatory testing for CROs. So if your lab has identified a Carbapenem-resistant organism that needs to be reported, and you're waiting for some kind of confirmation from the state lab, you will be waiting indefinitely. When your lab says it's a Carbapenem-resistant organism, it's a Carbapenem-resistant organism. And so, immediately start your response and get that reporting in. So it provides us with valuable information, and it saves you time to actually get that in. Because if we need this information and you haven't sent in your EPID 250, well, now we're required to call you and get all of this information so that we can know, was this an HAI? Was this present on admission? Do we need to conduct point prevalence surveys at other facilities that maybe didn't know about this organism when maybe they came into your facility present on admission? Well, that means it was present when they left the other facility. So get them in, and it'll actually save you some time. Finally, I just want to show you some recent trends. This chart here identifies PPS that we've conducted over the past couple months. Many of these on the list are associated with outbreaks. And many, if not most of these, came about as a result of poor communication between a transferring and receiving facilities. They weren't aware of the organism. They weren't aware of the need to place that individual in contact precautions. they didn't, and then so they were in this facility for some time then with no contact precautions, and that allowed for horizontal transmission. This is a jumbled mess, I know. Welcome to my world. I wish I was more organized and could put it in alphabetical order or something. But what you'll see here is this is a variety of locations, both in the state and both types of healthcare facilities, for a variety of organisms with a variety of mechanisms. So obviously, just one more note about PPS. When we see the need to conduct a PPS, we hope that initial PPS is negative. Once you have a positive round of PPS, you'll require 2 negative rounds spaced out 2 weeks apart to really rule out horizontal transmission. So you can see some of these have 5, 6. We've had up in the double digits of number of PPSs before the facility was actually able to get control of the outbreak. So I'm at the end of my time. Thank you for listening. We'll take any questions, comments, snide remarks this time that you might have.
Chad, thank you for that overview. I think when we have a problem such as the ones that are being posed by our gram negatives and other multi-drug resistant organisms, it's a reminder that the first thing we need to do is recognize the presence of the problem. And clearly, that this organism is all across the state. It doesn't belong to just one place. And so helping us begin to get started on understanding our reporting responsibilities and understanding our recognition, as you mentioned, early recognition. And to get this done, we need to begin with microbiology on how do we identify this. We need to certainly have at our starting point our clinical pharmacists, if we have them, or someone that is helping us look at antibiotic use. So we can not only understand, what is happening in terms of treatment, but also, the whole notion of how this is a prime example of the importance of antimicrobial stewardship. And so this is not just, a one-headed dragon; it's a multi-headed, hydra, and is a very complicated one for us in infection prevention. So one thing that I would ask of you, and I know our time is out and people are getting back to work, but when we post the recording, I'll put some additional information like the EPI 250, and if there are some documents that you think also would be important for us to post on the YouTube channel with the recording from today, we can certainly do that. As again, this is designed to be introductory information, that high-level overview, and realizing how problematic this is. There will be, I know, a number of questions. I think we also had somebody in the chat that said also recommendations on how long to apply contact isolation for the individual who is colonized. Is this, days, months, years, millennia? How long? So we can provide some of that basic information as well.
Mm-hmm. Yeah, there's been a couple of questions regarding that. And typically, the CDC really doesn't have an endpoint. So if you have someone that's identified with these CREs, crabs, you're going to flag them when they come back into your hospital. You will put them in contact precautions. If it's a long-term care facility, unfortunately, it's forever. That's the bad news. The good news is that if you're confident that there's no horizontal transmission, you can go to what the CDC has described as enhanced barrier precautions, which says that you would only gown and glove during those high-risk care activities. So if you're changing a brief, assisting with toileting, changing the bed, you would gown and glove. They would do contact precautions for those activities. If you're going in to sing happy birthday, if you're going in to, hang out and watch the last half of a ball game, you wouldn't be required to do that. So the idea there is that, some of these people can live a very long time in a long-term care facility, and we don't want, every time they have contact with another human being, they're wrapped up in a garbage bag and gloves. We want to have still that personal touch. And so,
Right. Yep.
So only
They're remembering,
cares.
Remembering to include environmental services in this process when you talked about the environmental components. So,
yes.
Right. Thank you very much. Dr. Ramirez, do you have any final questions or closing comments?
Have a couple of questions I wanted to add, but for my own information. Have we have in Kentucky CRE in community acquired infection? Have we have, for example, the worst scenario, young female with a urinary tract infection coming to the clinic, and I wouldn't have any antibiotic because the UTI is a CRE with a multi-resistant Klebsiella or E. coli. Have we or these are all problems at this moment in Kentucky in healthcare facilities, or we have it already in the community setting?
Yeah, that's a tough one to answer, and Dr. Spicer may have a more specific answer for you. But we certainly see people when these EPID 250s come in that tells the demographics of the patient. They may find a KPC in an outpatient clinic, maybe in the urine, or someone is admitted to a hospital. They have it present on admission, but they were admitted from home. So where did they get it? There's a question. Maybe they got it at a previous hospitalization. It's really hard to know. I'll actually be doing a presentation at CSTE next month, or whenever it is, discussing occupational exposure. We had a gentleman with a crab with a very, very rare Carbapenems gene, and he had not, typically on those genes you'll see foreign travel or hospitalization, frequent hospitalizations or hospitalizations overseas. He had none of that. He had none of those risk factors, but we think there's pretty strong evidence that he picked it up occupationally.
I see.
So tune into that. Tune into that talk at CSTE.
Dr. Eldridge, I have a question.
Okay.
Is there a talk to have a registry, where any hospital facility or long-term facility can go and see if the patient has CRO, like that will help with the communication part and placing people into isolation more quickly and all that?
Yeah, that would be great. I don't think we have anything
Any
like
other
that.
state has it or no?
Well, we don't have
jump in
anything that we share.
Can I jump in there?
Yeah, who is that?
This is Andrea. Yeah,
Andrea.
we are building a CRO registry, and currently it is populated with CRE. We have asked the developers to add Candida auris and crab to the registry. What is happening now as far as the evolution of this is that it is a system currently that you would sign on to, and you'd have to look for a particular patient. What is going to happen in the very near future is this data will be uploaded into KHI, and the records will be flagged so that when a patient is admitted or transferred to your facility, there would be a flag in KHI on their record. We've been working on this project for years, trying to get it up and going, and it's we're finally getting to a place where it will be beneficial to infection preventionists across the state. So if you're interested in signing on, getting access to this system as it currently exists, you can email Chad or myself, and we'll make sure you have that information on how to get a hold of us, and we can get you access to that registry. And there are very few states that have this, so we're in the forefront.
We're building our agenda now for a fall IP boot camp. And so this may be something that we want to include, kind of a demonstration of this, how to get the information so people can actually see what the vision is. And it's also a reminder that, we have to make sure about appropriate reporting. So we can make sure that's populated, whether, it's part of the standard HL7 data transfer, or whether it's going to be through the EPI 250. But notification becomes very important if this is going to be not only usable, but sustainable.
Right. And that's where, we're trying to get the interfacility transfer form to be used universally across the state. Many facilities will say, well, we didn't do the contact precautions because we didn't know. And the other facility will say, well, we told you, it was somewhere in the 1,000-page chart that we sent you. I think maybe about page 883 at the bottom. And so, okay, you got me. Yeah, okay, I guess you did inform me, but you got to do better than that. That's not good. So this form would come with EMS up on a transfer, and immediately, top of the chart, hey, this patient needs to go into precautions and for this reason. Or this person we have suspected something, they have cultures pending. Now you know that you have pending cultures that may lead to contact precautions.
Yes.
Very good. Then, Dr. Eldridge, thank you very much for this excellent presentation. We're going to keep looking at these multi-resistant organisms. We have already one talk regarding microbiology. This is another talk regarding our Kentucky Public Health project. We have another talk looking at the hospital environment. Again, we are trying to learn all these multi-resistant organisms from different angles, and this is the whole idea of this presentation. The topic may be the same, but it's going to be looked from the different aspects, as we did last time on the pathophysiology of central line associated bloodstream infections, and then there's so many different ways to look at these issues that we have with infection control and antimicrobial stewardship. Thank you very much for your attendance today, and we'll see you this coming Wednesday. Ruth, you will have the topic for Wednesday?
So Wednesday, I put in the chat this next session, Dr. Aaron Calhoun will be talking about simulation in infection prevention and control. So I think this will be so timely as we're thinking about how we can educate, train staff as we hopefully enter a new era with COVID. We've got to pick back up and address many of our infection prevention activities. So he will be presenting on that. So we look forward to it, and thank you very much for your participation. And we will be loading this on the YouTube channel for you to review or listen with others or use as part of staff training. And we look forward to seeing you back next Wednesday.